Conversations in Frailty, the podcast for Derbyshire clinicians.
Welcome back if you're one of our regular listeners, and welcome if Conversations in Frailty is new to you. It's been lovely to have some positive feedback on these recordings since the last one went out, and I did want to say again, do feel free to make this very much a three-way conversation. You can put comments in on Spotify or YouTube, and I'm always open to suggestions for future topics. So, getting down to today's episode, I'm back with psychiatrist Nick Long and specialist nurse Josh Kearney. We referred back briefly to episode 4 when we talked about depression, so do catch up with that one at another point if you haven't already heard it, but this one stands alone as well. Today our main focus is on anxiety, and we go through some useful tips that we can share with housebound patients who are struggling with anxiety and thoughts around suitable medication. And listen on too for some reflections around what makes a good referral for suspected psychosis in an elderly patient, beyond thinking about excluding delirium and pinch me. So, enjoy. So, I'm pleased to be having a further chat with Nick and Josh as before. Can you, people who haven't listened to the previous episode, just introduce yourselves for us?
I'm Dr. Nick Long. I'm a consultant old age psychiatrist working in the crisis services in North Derbyshire.
And I'm Josh Kearney. I'm a clinical lead nurse and non-medical prescriber working in the in-reach and home treatment team in the High Peak and Dales.
Great. So we've had a chat previously and gone into depression, particularly in the elderly population, and we wanted to just cover some of the other areas today. So I thought maybe we'd kick off with anxiety, because it's something we certainly in the community have to deal with a lot. About perhaps 1 in 5 older adults, 1 in 4, does that sound something?
Most likely, yeah. I think that probably anxious symptoms and other sort of akin disorders may be more common, but at the level that they're going to be coming to healthcare services is probably about right, yeah.
And thinking in a similar way to how we did with depression, I suppose, what do you see as the main sort of risk factors and the triggers for anxiety in this cohort?
I think with people with anxiety, it usually starts to have an impact on the daily functioning when people come into secondary services. So it's more sort of generalised across the board rather than sort of a sort of lower level anxiety about something happening. So it starts to sort of impact on how they're coping with day-to-day life. Mm-hmm. Usually at that point it starts to sort of tie in with more sort of mood element as well. I generally look at sort of anxiety alongside mood, because generally there's elements of depression and sort of lower level, less severe depression, with people with anxiety. So that's generally sort of what we see when they present with us.
I think we often find health becomes a more prominent issue in the older population. Health anxieties. Yes. We certainly, in a sort of general practice setting, see a lot of people coming in, and whether that's because they're less distracted by work anxieties because they don't have that, or whether it's they've got more medical conditions. So.
I think there might be some grown truth in that, because there's almost, you're not working and your kids are grown up and they've got their own family or however, so what do you worry about, and what does that mental space get occupied by? So I suppose it gives room for the gremlins to come in. Health anxiety can have a rational seed, and that's one of the key differentiators, isn't it, from psychosis? There's a worry that is from a rational issue or something that's feasible and within your own realm of reality, but then it gets held to an irrational degree. And if that continues, that can become a generalised anxiety that can be really very severe and disabling. Or as you say, sometimes the more specific health anxieties or particular worries can develop. Things like OCD, PTSD and other anxiety spectrum disorders clearly occur commonly within the group. Either things that have been difficult throughout the lifespan, particularly OCD. There is a cohort of people that have almost like a delayed PTSD, and you find this sometimes in the services, not just the armed services, but police and fire, where they've kind of gone through a career and multiple upsetting, difficult, challenging sorts of things have gone on, and then they come out the other end of that, and the box
When you stop.
that contains all of that, you know, the lid's not on as firmly as you hope, and sometimes these things can come back and be quite problematic, or something might almost re-traumatise, and it just links back to that that early memory. So it's that's certainly something that I've come across. I think some of the key things again is to make sure we're not diminishing the impact and the disability that's caused by it. It's trying to get through that clinical interview of, okay, well, is this now generalised anxiety? Is it about a specific thing? Is this actually depression underneath, or has it progressed to depression and that they've got an agitated depression type of presentation, and trying to get that differentiated there. And probably very similar conversations around access to psychological support as very much the first line, and much more so than perhaps for depression.
So, getting in that social prescribing or whatever we can do, rather than turning to medications as our first line.
And perhaps also, I think with the anxiety-borne problems, it's perhaps where psychological tricks, tips and different techniques come in. Hopefully as the generations that pass become more tech savvy, that because there are all sorts of apps and online programs and other things that can work you through these, but we often often look at particular techniques, sort of 5, 4, 3, 2, 1, box breathing, all these different things that you guys go out and
just talk us through a little bit of.
I suppose it's focusing in a sort of psychologically informed way, and sort of, as we discussed in the previous podcast, thinking around breaking down those barriers of having psychology versus having psychological intervention. I suppose that's where sort of we come in as nurses, of working in a more psychologically informed way with people. So we've got the grace of a bit of time with people to actually sit down and go through various techniques. I think we're starting to work through the aged population now that just turn up and say, thanks for seeing me, doctor, what are you going to do to make me better? And you're getting more people now that are sort of engaged in wanting to try things rather than expecting you to turn up with a pill and make everything fine again. So some of the things that we look at, especially in the crisis team, is the immediate sort of calming things. 5, 4, 3, 2, 1, name 5 things you can see, 4 things you can hear, 3 things you can, I'm going to get this wrong way around, smell, touch and taste. Basically focusing on the 5 different senses and bringing somebody into the here and now, because when you're in the middle of that sort of anxiety state where everything's out there, you can't focus on anything. Sometimes you need something just to ground yourself back to the present moment and just focus on the moment, and focusing on the different senses is one way of doing that, and it's something that can easily be practiced without anyone knowing either. You're not walking around sort of actively doing something where someone's looking at you thinking, oh, what's he up to? You just walking around and saying, right, these are 5 things I can see, chair, desk, cup, phone, okay, what can I hear? And it just brings you back into the moment. So there's sort of little techniques that we sometimes use. I mean, we developed something called the self-soothe bag that we sometimes take out with people, which has sort of various things in, like stress balls, putty, sort of nice lavender creams, balms, mints, that sort of thing, that is just a bit of a sort of quick grab this, do something to try and bring myself into the moment. And I suppose these techniques are useful in the short term, while we then look at what we can do to reduce the anxiety long term.
So we might be able to suggest these sorts of things to an extent,
Yeah.
if they're not somebody who's going to be referred, or while we're waiting for some input, because there's often a bit of a wait, isn't there? So,
there's lots of, I suppose, self-help services out there, especially on the web. Get Self-Help is one of the good ones that I quite often go to, because there's lots of therapy sheets, lots of help sheets that you can just print off without any copyright or anything like that. So
that's Get Self-Help.
Get Self-Help.
Okay.
Yeah, I can't remember, it's .org.
Yeah,
I think.
fine. We can Google that. Yeah, lovely.
But we quite often use things on there. The stop technique is a good one as well, that just helps you sort of stop, think about what's happening, try and be objective, and sort of consider what you're doing and move away and plan from there. So there's various things on there that are useful for people if they're at a stage where they can go away and focus on something and have a go themselves, that you can use just in everyday life.
The difficulty people have with anxiety clearly is an impatient state, isn't it? It's fight or flight, and a lion's chasing you, so I'm not going to hang around and practice something, but you've got somebody who, there's anxiety that is purposeless in a way, so it's trying to help that patient's focusing in on, okay, well, this seems to help, so let's just practice it and over, and this notion that it's not going to work quickly, but actually this is a much more sustaining and beneficial type of approach than medical treatment and so on, because it's actually, you can do it all the time, it practices, and if you look at fMRI studies of people with anxiety disorders, actually you see change over time with this kind of psychological process, because you're rewiring internally, but it's hard for people to see that, not because they're not psychologically minded or they're bad people or all of these things, but anxiety it's by nature an impatient state, because there's an emergency in your mind, isn't there?
Usually the best time to try these things is when you're not anxious.
Yes, to practice them in a quiet moment. Yeah.
When it's got to sort of generalised anxiety level where people are in that sort of constant state of arousal, it can be quite hard to go away and do something like this yourself, which is sort of, the people that come through to secondary services, anxiety is usually progressed by that point where they need somebody to sit and guide them through it. Whereas sort of Joe Bloggs, just who gets anxious about every now and again by something that's going to cause anxiety. There are techniques out there that you can practice when you're not anxious to bring yourself down, but sometimes you need that support to bring yourself back into the moment. And as Nick said, you're in that sort of fight, flight, freeze mentality where there's something that shouldn't be an anxious trigger that is triggering you and making you feel all sort of heightened up, and sort of in that state when everything's been just processed through the amygdala, you're restricted to a very short vocabulary because you're not having to use complex sort of thinking in those states. You're just thinking, do I fight this thing, do I run away from it, or do I freeze and pretend it's not there and it's not seeing me? So in that state you usually need somebody just to help bring you down. And usually it does subside, adrenaline only circulates around for so long, doesn't it? But in the midst of that sort of anxiety state, it can feel very scary and very frightening for people. So.
And moving to medication, because sometimes we don't have great access to these services. I suppose one first thing is with deprescribing. Are there things that you commonly see that you think are actually exacerbating anxiety in terms of anything? Parkinson's, sometimes medications?
Or Parkinson's meds. Oh, that's a whole other podcast probably. Get back to Geneva. And that's a complex area, because yes, that does increase agitation, irritability, but it also increases your ability to move around. Which is quite fundamental. So it's it's one where we talk and try and get the balance with sort of across the specialties there. Anticholinergics are worth thinking about. In our game, people on antipsychotics, perhaps for other things, the question is sometimes is it akathisia, which is related to sort of the Parkinson side effects of driving, restlessness, often in the lower limbs, and it feels like ants in your pants basically, and you can't sit still. And is it, I suppose, just making sure it's not something like that, or something that might also be prone to causing Parkinson's-like effects.
So going back, you just said, so the anticholinergic burden, we often think of that as causing confusion, but actually anxiety can be a presentation as well.
Well, if you think about being confused,
that can be anxious, that makes sense. Yeah.
And it can do all sorts, and it's sometimes why people don't like sedation either, or why you get a paradoxic, or what seems to be a paradoxic effect with sedation in dementia, because you've actually just made somebody confused. If you think about those times when you've maybe had one or two glasses of wine more than you intended, and it actually doesn't feel very nice. You feel a bit weird, you feel uncertain, the world around you is actually, it creates quite a sense of anxiety and threat and fear, and if you've not intended to be sedated or confused or otherwise mentally changed, it's not a nice thing, is it? So I suppose it's important to think about those ones, and sort of in particular medicines for the bladder and things like amitriptyline we commonly see. I guess another one more, if we come on to things like psychosis and mania, prednisolone.
Could certainly induce. Yeah.
But prednisone's got quite a wide neuropsychiatric side effect potential. So we don't tend to do too much deprescribing in anxiety per se, but it's worth thinking about those things more from confusion, secondary agitation, anxiety, and so on.
And then sort of, I guess you'd probably say following the guidance, but in terms of what you'd prescribe as an anxiolytic.
Usually down sort of the SSRI route
again, probably.
And we use things like diazepam quite frequently, but we use them sort of with the caveat of we're going in there to do something to then replace the diazepam and slowly draw that away, because you generally get sort of two cohorts. You get the people that come through with long-term anxiety that have just ended up on diazepam all their life, and you kind of think, is now the right time to try and take that away from you as well, or is it sort of a lesser of evil of sticking with it? And you get the people that come through that just use it episodically, where you think, actually, it's going to be useful here, let's put some in just to try and bring it down a little bit, so you can then get to the point of being able to sort of use psychologically informed techniques with people to help them sort of manage and deal with that, with the idea of then gradually drawing the diazepam away with somebody.
I suppose we're at the pointy end with that cohort, so we're obviously looking at trying to help people who would suffer dreadfully probably if admitted to a psychiatric ward, or have got other risks, including suicide or self-harm, etc. So that's kind of trying to help bring something down from redlining. Obviously they come with risks. A big psychological risk is that if you pop a pill for that panic feeling or that other thing, that works in the moment. So thanks for your 5, 4, 3, 2, 1, Josh. But I'll have the blue one. That works better, and it just it disables even probably what somebody might have come to themselves to try and help contain and manage themselves, because people do a lot to try and fight and support themselves in the midst of these things. So it's quite disabling of those techniques, and there's an increased risk of dementia with chronic benzo use, amongst other things. So we can add that to the...
For us in the community, seeing it at a lower level, we shouldn't be turning to the benzo, should we?
Unless it feels like an emergency.
Unless a real crisis at the point.
And in the previous conversation around depression, obviously mirtazapine's got quite a strong popularity, but the evidence for its benefit in anxiety is poor.
Okay.
So we have much more faith, I suppose, within the SSRI group and those things, but it takes time, and again, there's someone with an alarm going off in their brain, isn't there? There's something's dire warning, so if it's not better today, then what's this treatment doing? It's not doing anything, doctor, and it's and that therapeutic patience is hard all round, isn't it? We do see quite a few folk treated with pregabalin, which is obviously a nice guidance and third line. I suppose we worry in this group much less about the sort of drug divergence and things getting sold off, and we're using doses of 25 milligrams, which I don't think ne'er-do-wells would be particularly bothered about having and we can get good effects from that. We've seen quite a few sort of positive results. The risk often with this group being more the postural hypotension and brain fog that comes with it. So they're the balancing factors, but again, that sort of treatment tends to allow then enough calm so that the alarm's still going off, but we'll listen to the alarm, we know it's safe, it's all right, so we can try these other techniques, we can try these other things whilst things are diminished enough, and it probably carries less long-term risk than sort of that route down with benzodiazepines and so on.
The other thing to consider as well is we quite often tell people it's probably going to get worse before it gets better when we're starting sort of SSRIs, because of the risk of that initiation effect. You sometimes get an increase in sort of the agitation sort of in the early days, so it's trying to support people through that and recognise that for what it is, that is it a worsening anxiety or is it just actually initiation of antidepressant treatment that you just need to support somebody through.
So they don't just start it and stop it, and, which we see otherwise.
Because in that sort of anxious state, you get that hypervigilance of looking out for any sign of anything getting worse, and then taking quick drastic action because it's got worse than it was this that was started, therefore we're going to stop taking it. So sometimes people need a bit of support just to pursue through that and come out to the other side of it.
Great, so that's, I think covered anxiety quite well, and I thought we wanted to just touch on, before we finish, a little bit on psychosis. We mentioned that with the steroids, and psychosis isn't something that we fortunately see a lot of in the community, but just thoughts around psychosis in this frail elderly population.
So it remains a really important presentation, and the key thing about psychosis is it's not a diagnosis, it's a description of, it's a clinical syndrome almost, isn't it? So that the key thing is some absence of normal reality, so be that hallucinations or delusions or disrupted thinking. Within frailty, clearly the key cause of psychotic symptoms, especially if they're abrupt and they've got visual hallucinations, is going to be delirium.
Yeah.
Being really clear that that's the absence of result on a blood test or a positive urine dip doesn't exclude delirium.
I think
as I'm sure most know, but I just had to get
is
that
out
in.
there now, and I think people are now starting to think a little bit more broadly than UTI, fortunately.
But I think within frailty particularly, sometimes you might not find the cause, and yes, we know that that's the way to treat delirium, is to find the cause, but people can be so vulnerable to delirium and the cause might have come and gone, and if it's got that particular clinical picture, it's delirium.
So the cause may have come and gone, but it persists, the actual psychological effects persist,
and that can be for 6 months. Again, dementia is another cause of psychosis, and sometimes that can be almost like a herald symptom. So that's something to think about. Again, it's got that more commonly organic feel to it, predominance of visual hallucinations, bizarre or disjointed delusional beliefs. Probably the group of affective disorders, it's unusual to get mania for the first time in late life, although we do see it. We did see it very recently. Somebody who's never had any depression or no mania, hypomania through life, even after repeatedly asking many people, absolutely nothing. So that's uncommon. Depression with psychosis is more common, and again, just making sure, thinking through, there are other features that suggest depression here. Is there a nihilistic aspect to it, or delusions of poverty, or destitution, those sorts of things more common. Guilt, sometimes kind of an excess morbid focus on something that might have happened in early life that's going to catch up with them, is a common content, and it tends to have that feel to it, and that's an alarm bell presentation. So features of depression, psychosis within that's
so for us,
don't pass go.
If we were seeing it, our first thought
Mm.
should be to try to think, is this a delirium, and work on the basis of that. But if we don't, actually it's referral into the CMHT for older adults. Presumably we shouldn't be starting antipsychotics in the community. Would you be arguing, or?
Probably not. And if you know somebody and they've got a chronic psychotic condition, I think that's something that it'd be a shame to say that you have to refer to secondary care to say, well, Jim's always responded to olanzapine.
Sure.
I could press the button, or I could ask a friend. Broadly speaking, I think it's one of these things where that more urgent input and say, let's try and fathom this out. This is why I don't think it's delirium, and as much as that is excluding the underlying causes that are physical emergencies, that is also described in the clinical syndrome. There's no clouding of consciousness, there's no fluctuations. These are auditory hallucinations with associated secondary delusions, and that's clearly different. Because we've got a range of other things that we'd think about the affective psychoses. What many years ago used to get called paraphrenia, but now we have to call very late onset schizophrenia like psychosis, which is an awful name, isn't it? but not that uncommon a presentation for us. So there's onset usually after the sort of 6th, 7th decade of quite striking positive psychotic symptoms in the absence of any clear underlying cause. So those things would normally require that specialist assessment to tease out what's what in a discussion about antipsychotic treatment. And
And I guess also that links back to our previous discussion, just thinking, you mentioned psychosis in depression. If we see psychosis in depression, that's a real alarm bell for potential risk factors for self-harm. So
I suppose this is where sort of having sort of good referral information from primary care is useful, because we talk about sort of risk factors with sort of high chance of it being delirium and things like that. So having the referrals that sort of cover what's been done, what's been ruled out, or what we've tried to rule out is very useful for us, because it stops us. And then if we get that referral, we'd be sort of saying back, well, have you checked these things? And then, do you know what I mean? It can then cause a bit of delay and back and forth between services about sort of where someone sits and what have we checked and what have we not checked. So when we get those referrals that say, done bloods, done all this stuff, know this person really well, it sits more of a sort of psychotic nature,
then it will flow through
help.
better rather than, I think we've all seen that sort of bounce back to us. So actually just a good referral is one where we are clearly laying out why we don't think it's a delirium, and then over to you. Yeah,
because usually by the time people have reached that age, they've got a very good relationship with the GP, and you see those very good referrals where the GP obviously knows the person very well, covers sort of what the background is and what the history is, what the current presentation is, and from that straight away you can see, it looks like psychosis, it smells like psychosis, let's crack on and treat psychosis. Whereas you sometimes get those very sort of quick referrals that come through when people are rushed.
And I think just a quick angle on that as well is often you might carry some knowledge about past malignancy or past illness or other things, and you can say, well, that what's really useful to us is, well, that prostate cancer is low level and in abeyance with treatment, or
we're not worrying about brain mets,
but they had treatment, and as you say with brain mets or other sort of sometimes paraneoplastic syndromes or so on, or you say actually they might have malignancy, but this was the decision about that, not to investigate. So we know what if you know what your uncertainty is, then you work
puts you
with
in
that.
The picture better.
If you've just got an uncertainty that you don't know anything about or don't know, then that's useful in itself. Because again, you're closing off things that it could be, or you're opening up ideas about what might be. But especially in the context of frailty, this might be the case, but we're not going to look at that. So
and
I think include it in our goals-based approach.
One of our big things, isn't it? When's the appropriate moment to keep investigating, and when's the appropriate moment to stop? Well, thank you both again for having a further chat. So it was really useful to cover anxiety this time and to touch on psychosis as well.
You're welcome. Thanks so much.
Well, I hope, like me, you've picked up some useful tips for your practice here. It did occur to me that we discussed some self-help tips here, but of course don't forget that if your patients are up to it, the telephone talking therapies are always an option. There was a recent Centre for Mental Health briefing which came out, which Age UK had commissioned, and they noted that NHS talking therapies are less likely to be offered to older people, but actually they have higher than average recovery rates among the over 65s. So it does work and it is available. I was thinking about Dr. Long's description of anxiety as an impatient. I thought originally he said inpatient, but an impatient state was quite interesting. The fact that the mind is in a state of emergency in our anxious patients, and maybe that helps us to empathise a bit more with the struggle between them wanting the quick fix tablets and us trying to encourage the psychological therapy side of things. Ultimately, there is good evidence behind the psychological therapies and even the self-help techniques as the brain rewires, so good motivation for us to encourage that side of things. They refer to a self-help website, which is getselfhelp.co.uk. It's got some great patient information, leaflets and worksheets on many topics, including anxiety. And it did occur to me it could be a resource as well to help a carer who has a frail relative with significant anxiety. As an aside, I also happened to spot that they have an excellent template for a suicide safety plan. And then finally, we were reflecting around referrals to the CMHT for possible psychosis in older adults. And I think it was a good reminder to us that actually the team won't have access, as some of us do, to details around things like cancer stages or investigations that have been declined, and that can also be lots of useful information for them, in addition to obviously excluding likely delirium. So as I said, if you want to delve more into the depression side of things in this cohort of patients, then head for episode 4. In the meantime, it just remains to say, have a lovely Christmas, and do join me again in the new year for another conversation in frailty. As always, remember this is a discussion with 2 experts in the field, so when making individual decisions about patients, always take local and national guidelines into consideration, and of course, use your clinical judgment.
Conversations in Frailty. Thanks for listening.